are going to review Chapter 4, and we're on page 52. Chapter 4 is about pharmacy practice, and again, this is from the Federal Law Course book that is produced by RX Prep or UWorld, and we're in the 8th edition manual. All right, so we have page 52, and we're going to go through responsibilities of the pharmacy staff. All right, so this is going to go through the pharmacist collaborative practice agreements, pharmacist in charge, interns, technicians, clerks. The pharmacist on duty is responsible for supervising the daily operations of the pharmacy to ensure that all of the activities in the pharmacy are performed safely, in compliance with the law, and without risk of harm to patients. The pharmacist is responsible for supervising the pharmacy support staff, so that includes technicians, interns, and clerks. The traditional role of a pharmacist is the safe and proper dispensing of medications. When a pharmacist signs off on a prescription, the pharmacist is confirming that the dispensed medication matches the prescription and the safety risks have been evaluated. This will include allergies, contraindications, warnings, adverse events, and drug interactions. Pharmacists have the discretion to decide on the best course of action for a patient based on their professional judgment. This includes decisions on whether to fill a prescription when the prescriber is not able to be contacted, or if a prescription should be filled at all. For compounded medications, the quality of the product is the legal responsibility of the pharmacist, and not the technician who prepared the product. When the pharmacist signs off on the compounded product, it indicates that they verified that it was made correctly. So let's go through that again. So with regard to compounded medications, the quality of the product is the legal responsibility of the pharmacist. It is not the legal responsibility of the technician who may have prepared the product. So when the pharmacist signs off on the compounded product, it indicates that they verified that it was made correctly. Technicians can still face consequences for being careless, and they can also face legal action if any theft or illegal activity is observed to have occurred. Many pharmacists, they perform clinical activities for patients, and some states permit pharmacists to have provider status, such as advanced practice pharmacists. Provider status essentially enables pharmacists to receive compensation for the clinical services that they provide. So let's see here, collaborative practice agreement. A collaborative practice agreement, or in some states, collaborative drug therapy management. So the CPA, collaborative practice agreement, also known in some states as collaborative drug therapy management, or CDTM. It's a formal relationship between a pharmacist and another healthcare provider or a provider group. The healthcare provider makes a diagnosis, supervises patient care, and refers patients to the pharmacist to manage drug therapy, which is a form of prescriptive authority. So the collaborative practice agreement might allow the pharmacist to initiate, to modify, and also to monitor drug therapy. Let's see. examples of these activities may include that the pharmacist, for example, in a primary care clinic, may be allowed to order hemoglobin A1Cs as well as review glucose trends to be able to adjust insulin doses in patients that have diabetes. Another example here of a collaborative practice agreement could be in an anticoagulation clinic. So the pharmacist there could order INRs and adjust warfarin doses accordingly. So again, the collaborative practice agreement may allow usually the clinical pharmacist who's residency trained to do those things. So as we have seen, for example, like in the veterans hospitals, some of the pharmacists are specializing in ambulatory care, and so they are working with patients with metabolic disorders, which includes diabetes, and helping to manage their blood pressure, their sugar, and things of that nature, their cholesterol as well. So in this other instance of working in the anticoagulation clinic, that would typically be someone who is trained in the specialty, the residency first. They would do their general residency, and then they would do 1 year of specialty of cardiology if they were going to be a pharmacist, clinical pharmacist working in the anticoagulation clinic. It does say here that nearly all states do permit pharmacists to enter into these collaborative practice agreements. Let's keep moving. We're on page 53. We have the pharmacist in charge. So the PIC or pharmacist in charge, they are responsible for managing other pharmacists like staff pharmacists and floater pharmacists. While any pharmacist on duty would be responsible for day-to-day operations and technician oversight, the pharmacist in charge, or the PIC, is the primary person who's responsible for the legal operation of the pharmacy. The PIC must ensure that the pharmacy is compliant with federal and state law. The PIC's license could be jeopardized in terms of warning, suspension, revocation, if there's any inappropriate or illegal activity that's occurring in the pharmacy. So there could be things like incorrect record keeping, improper staff ratios, drug theft and diversion, which is happening by maybe some of the staff. There could be a lack of counseling or inappropriate counseling occurring. So additional regulations in some states may include limiting the number of pharmacies that the PIC could supervise. Secondly, setting a maximum physical distance that is permissible between pharmacies if the PIC is responsible for more than one location. Thirdly, requiring a minimum number of hours that the PIC must be present in the pharmacy. And fourthly, requiring a pharmacist to complete a minimum number of years of experience as a staff pharmacist in order to serve as a PIC. So let's see here. Let's move to page 54. Let's review the pharmacist intern. So the intern, occasionally called a student pharmacist, again, as we know, they're training to become a licensed pharmacist, and they can perform some of the pharmacist functions at the discretion of the supervising pharmacist. The tasks that the interns might perform and the required level of supervision will vary from state to state. Such differences may include the number of interns that can be supervised by one pharmacist, and The intern may be prohibited from transferring controlled substance prescriptions, completing final verification, or having a key to the pharmacy. In order for the pharmacist to provide adequate supervision, they have to be trained and legally permitted to perform all of the activities that the intern will perform. For example, a pharmacist that supervises an intern providing immunizations, they must be trained in immunizations themselves. So, for example, both the pharmacist that is supervising and the intern, they must both already be trained in immunizations in order to practice together. Let's keep moving on page 54 and review pharmacy technician. So pharmacy techs, unless they have specialized training or any advanced certifications, they can only perform non-discretionary tasks. So those that do not require any clinical decision making. The legal requirements to become a technician and the number of techs that can be supervised by one pharmacist, it will vary from state to state. Pharmacists perform direct supervision and approve tasks performed by technicians. Some states do permit the Tech Check Tech TCT program, which bypasses the need for pharmacist supervision or approval in certain circumstances. So in the Tech Check Tech TCT programs, a technician, usually that has additional training or certification, can check another tech's work, and this will often add or be using additional technology. So for example, a hospital pharmacy may allow Tech Check Tech on medications that are pulled from devices that use barcode scanning. So for example, carousel drug storage units and robots for accuracy. In many states, techs can perform the following tasks under direct supervision of a pharmacist. So first, they could enter prescriptions into the computer, so data entry. Second, they can communicate with patients and insurance companies. Thirdly, fill prescriptions, including removing drugs from stock, counting, placing drugs into the container and labeling the container or bottle. Fourthly, in certain pharmacies, they may be able to compound sterile and non-sterile medications. 1, 2, 3, 4, and then number 5, they might be able to stock medications in the automated dispensing systems or cabinets, such as Pyxis or the McKesson AccuDose RX or Omnicell. They also may be able to stock medications in the emergency crash carts. Lastly, we're going to go through pharmacy clerks, which are typically what we used to see like in some of the wholesale places. Even Walmart, in certain states, they had pharmacy clerks or cashiers that were not technicians. So some states, they do allow clerks who are non-licensed personnel with no specific training to perform limited functions in the pharmacy. Clerks cannot be subject to license suspension or revocation since they don't have a license issued by the Board of Pharmacy. The pharmacist that's supervising the pharmacy clerk is responsible for ensuring that the work that they do meets requirements of state law and federal law. The tasks that the pharmacy clerks perform will vary from state to state. They cannot fill prescriptions. In states that allow clerks or cashiers, there are usually no limitations on the number of cashiers or clerks allowed in the pharmacy area, pharmacy department at one time. And this is something that would leave the number of permitted clerks up to the pharmacist's discretion. typical functions that the cashier or the clerk might perform would include they could accept like a drop-off prescription at the drop-off window. They could verify patient insurance coverage, and they could complete the transaction at the pickup window. We're going to keep going. We're on page 55, and we're going to review requirements for valid prescriptions. And let's see, refills, transfers, labels, and yeah, we'll keep going. So in terms of requirements for valid prescriptions, again, we're just reviewing. So let's see. In the last chapters, we went over the Durham-Humphrey Amendment of 1951, which established the criteria for determining if a drug is prescription only or over the counter. Excuse me. So that amendment allowed for the dispensing of medications according to a valid written prescription or an oral prescription, which is then immediately reduced to writing. With the advancement of technology, states passed laws permitting faxes and e-prescriptions. So the e-prescriptions or e-prescribing, it is now highly encouraged and even required in some states. Elements required on a prescription may vary by state. The National Association of Boards of Pharmacy, the NABP, recommends that a prescription should minimally have the following. So it should have the patient information like the name and their address, the prescriber's information, so the name of the prescriber, their address, and their typically NPI or DEA number. It should also have the drug information, so the name of the drug being ordered, the strength, the dosage form, the quantity, also directions for how to use it, and if there's any refills. It also needs to have a date on it. And lastly, it needs to have a prescriber's signature. We're going to move on to page 56. So we're under the heading of tamper-resistant security forms for Medicaid beneficiaries. Federal law mandates that outpatient Medicaid prescriptions be written on tamper-resistant security forms in order to be eligible for reimbursement by state Medicaid programs. These security forms must contain at least 3 tamper-resistant security features. This doesn't apply to electronic, oral, or faxed prescriptions. The Center for Medicaid Services required security features must include at least one feature from this list. So there has to be a feature that prevents duplication. So for example, the word void might appear when it's photocopied or faxed. Secondly, it should have a tamper-resistant feature such as prevents erasure or modification of the written information. So for example, with quantity checkboxes, refill indicators, or with chemically reactive paper that changes color when an eraser is applied to the paper. Thirdly, prevents the use of counterfeit forms. So for example, pre-printed serial numbers, watermarks, or microprint signature line. We're going to keep going on page 56 under healthcare providers and prescribing. Healthcare practitioners that are licensed to prescribe medications can include MDs, DOs, dentists, doctor of podiatry, so podiatrists, DVMs, veterinarians, NPs, nurse practitioners, some pharmacists that work in the VA that are residency trained. They are clinical pharmacists that may have prescriptive authority. Some optometrists and naturopathic doctors as well can prescribe medications. Independent and collaborative prescribing authority will vary by state. Before dispensing a medication, the pharmacist has to make a good faith effort to determine that the prescription is valid, which includes determining that it has been written by a valid prescriber. Physicians have unlimited independent prescribing authority in all states. All other prescribers can only prescribe within their scope of practice and or under a physician-directed protocol. So here's an example. Some states limit naturopathic doctors to being able to only prescribe natural drugs and occasionally epinephrine and testosterone. A dentist would be limited to prescribing medications relating to the oral cavity and dental procedures. An optometrist would prescribe medications relating to ocular conditions or disorders. In contrast, an ophthalmologist, which is a physician who specializes in ocular conditions, they could prescribe outside of their specialty, although some states specifically limit physicians to prescribing within their scope of practice. Obviously, we have to go and review valid prescriber-patient relationship. So that's what we'll look at next. We're on the bottom of page 56. In order to fill the prescription, the prescriber and patient relationship must actually exist. So the National Association of Boards of Pharmacy, NABP, recommends that each of these conditions should be met for the prescription to be considered valid. So first, the patient reports a medical issue or a condition. Second, a medical history has to be taken. Third, there has to be a face-to-face physical examination or telemedicine examination, which is adequate to establish the medical issue that they are complaining about. Thirdly, a logical connection has to exist between the medical issue, their medical history, the physical exam, and the drugs or drug prescribed. Moving on to page 57, we're going to go through self-prescribing or prescribing for family members. So the AMA, the American Medical Association, recommends against physicians treating themselves, which is called self-prescribing, and that also recommends against physicians treating immediate family members. The DEA does not address this prescribing, but individual state medical boards and pharmacy boards can prohibit or limit this. Some states limit this prescribing to medical emergencies, short-term or minor issues, or limit the allowed drugs. So for example, some states may prohibit the prescribing of a Schedule II drug for themselves or a family member. Some states may prohibit all prescribing of scheduled drugs for themselves or an immediate family member. If treating an immediate family member is permitted, a valid prescriber-patient relationship, again, it must exist. There are ethical limitations involved with self-treatment and with the treatment of family members. Prescribers might not be able to be objective, and they may not adequately examine or interview the patient that they're, in family with. They may not order appropriate diagnostic tests. They may bypass that altogether. And they may not order the proper drugs or even counsel because of the personal relationship. Self-prescribing, it has the potential for abuse and misuse. In some states, they do not limit or they may have partial limitations on this type of prescribing. The pharmacist will need to use professional judgment on whether or not to fill the prescription. So we're moving on, page 57. We're under prescriptions from retired or deceased prescribers. Federal law, it does not specify whether a prescription remains valid if the prescriber retires or passes away. Some states do address this issue and others do not. For states that do address this issue, common scenarios might include the prescription may become immediately invalid, or the prescription may be valid until it expires, or the remaining refills are exhausted, whichever comes first. If there is no state guidance, then the pharmacist should use their professional judgment when they're deciding to fill or refill a prescription. If the prescriber is no longer practicing, then the pharmacist should encourage the patient to find a new prescriber as soon as possible and not wait until their prescription expires or runs out of refills. We're at the bottom of page 57. We're under prescriptions from other states, U.S. territories, or foreign countries. In most cases, a prescription written by an out-of-state prescriber or territory is valid if a true relationship between the doctor and the patient is actually present. Some states have specific rules for out-of-state prescriptions, like they require them to meet requirements for in-state prescriptions, for example, tamper-resistant forms, or only allowing non-controlled substances to be filled from out-of-state doctors. Some states do not allow prescriptions from other countries to be filled, and some states do not specifically address these topics. States that share a border with Canada, for example, like Washington State, New York State, Texas shares a border with Mexico, so does Arizona. Those states are typically more likely to allow filling prescriptions from Canada or Mexico, but with limitations. Moving to page 58, we're under the heading of off-label prescribing and promotion. Off-label prescribing essentially means that the drug is prescribed for a purpose other than the FDA-approved indication. FDA-approved uses are listed in the package insert. If a drug has been approved for at least one indication, prescribers are legally allowed to prescribe it for other purposes if they feel that it's safe and effective for the patient's health condition. Off-label use includes using the drug for the indicated condition, but maybe in a different patient population. The drug manufacturer and their drug representatives cannot initiate conversations with healthcare providers regarding the off-label use of their medications. Manufacturers and their representatives may discuss off-label use if a healthcare practitioner has requested the information. Off-label prescribing is pretty common. It's often beneficial, and the use may even be included in clinical guidelines. Occasionally it is inappropriate and it might be unsafe. Here's an example. So it's saying this example is a drug that is commonly used off-label, like gabapentin. Gabapentin is FDA approved for the treatment of post-herpetic neuralgia and for adjunctive treatment of partial onset seizures. However, it is used clinically for a wide variety of indications like neuropathy, neuropathic pain. It is included in several guidelines, including the American Diabetes Association, as an appropriate treatment option for that indication. Pharmacists are legally permitted to fill prescriptions for off-label indications. Pharmacists must use their professional judgment when filling off-label prescriptions. Before filling a prescription for an unfamiliar off-label use, the pharmacist should attempt to find out if the drug has been studied for that purpose, if it is likely to be efficacious, and if it appears safe for the patient. The pharmacist can research the use and/or request supporting literature from the prescribing doctor. We're under the heading of correcting errors on prescriptions on page 58. The pharmacist can revise errors on a prescription that's for a non-controlled drug if the error is minor, such as maybe the drug name was misspelled. If the error is not minor, then they need to contact the doctor who wrote the prescription and document their discussion, including the agreed changes. An omission is a type of error in which required information on a prescription has been left out. For example, maybe the number of tablets. The doctor maybe forgot to write how many tablets to dispense. After verification with the prescribing doctor, the prescription can actually just be rewritten as an oral prescription. In some cases, the original prescription will then be voided and the prescriber can resend another prescription by fax or e-prescription. Correcting errors and omissions on prescriptions for controlled substance is more strict, and that will be discussed in Controlled Substances Chapter Part 3. We're at the bottom of page 58 under the heading of prescription records. Most states mandate that prescription records have to be maintained for at least 2 years. Some states have stricter requirements. The longest is actually the state of Arizona. Arizona requires that prescriptions be kept for 7 years. All right, so we're going to take a break here, and then we'll come back and we'll be on page 59.